Hey guys,
Hey.
welcome to the first week of PGHE. This is the first session of the course and it's going to be led by our Vice Chancellor, Professor Agnes Binagwaho, and it's titled Introduction to Global Health Equity. Enjoy.
Dear students, today's lecture is focused on exploring what global health equity is. We have the following learning objective. First, it is to understand the importance of biosocial approach to global health challenges. Second, it is to introduce you to system thinking for health. And third, to define global health equity and other key terms. Many diseases have biological and social roots. This means that the condition in which people are born, grow, live, work, and age, including the health system, are circumstances that are shaped by the distribution of money, power, and resources at local, national, and global levels. These circumstances are themselves influenced by international, national, and local policies and are called the social determinant of health. The social determinant of health are mostly responsible for health inequities, the unfair and avoidable differences in health status seen within and between countries. However, most common public health interventions are only biomedical and don't tackle the social determinants of health. And understanding the biological and social roots of the problem can help you understand what has gone wrong and think about real solutions. A great example to illustrate the social determinants of health is tuberculosis. Because it is a multifaceted and needs more than pills or medicine to be treated, like all social illnesses, tuberculosis requires strategic and long-term thinking. These slides show you two facts for you to analyze. The first is the natural decline of the burden of tuberculosis even before the discovery of medicine to cure it. And this occurred since the 19th century because of improvement of life conditions. Second, you can see two peaks that show cases and with an increase of prevalence of tuberculosis linked to the challenging time for wellness during the two World War. TB is a disease of poverty, and the social determinants of health driving it are poverty, overcrowded living condition due to a lack of space for living and money to afford a better living standard, indoor air pollution due to the fact that the family is too poor to pursue non-polluting technology such as clean cooking fuel and improved cooking stove. Malnutrition because not having enough money to feed each member of the family. Tobacco and alcohol are linked to the social determinants of health and the status of the family. And then not only push people into the habit of tobacco or alcohol, those social determinants of health, but the use exposed women and children to domestic violence and create the vicious cycle of addiction and poverty. And finally, stigma and social isolation. For sure, sometimes non-vulnerable individuals are infected by TB. For example, this could happen when they are in contact with disadvantaged people affected by tuberculosis while giving care and support, but these are the minority of the cases. This illustration of this is an illustration of the link between education and exposure to tobacco. In Denmark, children with parents with low level of education are 11 times more likely to be exposed to tobacco smoke in the home. And we know that the level of education is linked to socioeconomic status. And same for alcohol. This is why tobacco and alcohol are count among the social determinant of health for tuberculosis. This slide illustrates how poor people face the triple burden of disease. The first one is poverty. Poverty itself that causes stress, mental health disease, and is also one of the major social determinants of health. The second is high burden of disease, many disease, due to inadequate knowledge that creates late demand for care and various behavioral risks. Disease directly linked to poverty, such as malnutrition, mental health, such as depression due to high level of stress, such as gastroenteritis due to lack of or access to clean water, and many others. Third, the lack of access to quality health services because of financial barriers that limit their ability to for transport to reach the health services or their ability to pay for services. Look at this house. In 1994, we had many houses like this in Rwanda. But during the last 10 years, such thatched roof houses have no longer been allowed to be built. But the burden was not put on the poor who can't afford more secure and better house, but to the local leaders who have to reallocate them using local budget and at no cost. And today in Rwanda, when one such house is found, the mayor gets in trouble. The circumstances in which the poor lives create a vicious cycle of disease and poverty. It is a cycle that can be described starting at any point of the cycle. For instance, poverty brings with it less access to food, less access to clean water, health, and schooling. This leads to hunger, poor sanitation, poor education, and increase the risk of diseases such as malnutrition and even death. All these cause fewer work opportunities, high level of unemployment, and low family income. It is important to understand that poor families will remain in these circumstances, struggling with the disease of poverty, passing them down to next generation, unless there is an intervention coming from outside the community that can be led by either the government, the central government, the local government, or by NGOs, but the poor need help from external sources. We are now going to explore different health systems and how we can analyze them using strategic thinking. I will start by telling the tale of two health systems, one that is resilient and one that is fragile. A profound shortage of skilled health professionals are both the causes, and the consequence of fragile health system that plague much of the developing world. The recent 2014-2015 Ebola outbreak in West Africa, which has claimed over 11,000 lives, illustrate that phenomenon. Years of civil unrest and displacement of population, coupled with chronic underinvestment in health and health education, severely depleted the health workforce. In this setting, there was little to stop the rapid spread of Ebola. I'm talking about Sierra Leone, Guinea, and Liberia. In these countries, during the outbreak of 2014-2015, frontline workers without adequate training or personal protective equipment were disproportionately vulnerable. In Liberia, a country which had only one physician per 100,000 population before the epidemic, an estimated 8% of the country's healthcare workers were killed, with the remaining workforce unable to safely deliver basic primary health services. Thousands of additional preventable deaths are projected to occur. These slides show the case death rate for Ebola infection in the 3 countries affected by Ebola in 2014: Sierra Leone, Liberia, and Guinea. The following slide illustrates what are the 4 S's and shows a photo of health facilities in one of the 3 West African countries affected by Ebola in 2014-2015. It shows also a very high rate of mortality caused by the weakness of the health system, with too few qualified and trained qualified staff, as well as an absence of equipment and infrastructure, like shown in the photo. So the provision of care was very difficult. The slide shows also the high rate of death in West Africa, 83% of positive cases of Ebola, 4 times higher compared to Europe, where it was 22%. And this was caused by the lack of staff, space, and system. What we call the 4 S's: the staff is the equipment, the space is the infrastructure, and the system is the health system comprising the health workers. These numbers, 83% and 22%, are numbers for the Marburg hemorrhagic fever caused by a virus of the same type as Ebola virus and provokes the same type of symptom of fever, hemorrhage, and multiple organ failures. Both diseases have no treatment, and patients receive the same type of care. This is why the number for Marburg hemorrhagic fever can be compared to the Ebola outcome. For comparison, during COVID-19 pandemic, the case death rate in Africa was 2%, not 83%. It's to show the difference between the 2 types of outbreaks. Even if COVID-19 is a pandemic and Ebola was not, Ebola is far more deadly. In global health, there is a problem of gender parity. The majority of healthcare providers are women, especially at the front line. Despite that, the majority of people in leadership positions are men. This is why when there is a highly deadly contagious disease like Ebola, putting health professionals at risk the number of women who die is higher than the number of men. This article from the Washington Post about Liberia report that 75% of those who were infected by Ebola or died from Ebola were women. This lack of gender parity also results not only at the frontline work in health facilities, but more exposure to risk outside the health system as women provide the majority of care to the sick at home. Dear students, we have finished the first section of this course. In the second section, we will analyze the example of Rwanda, and in the third section, you will be introduced to global health equity. Thank you.